Question 1. A 35-year-old male patient presents with the chief complaint of blurry vision in both eyes. He mentions a history of mild eye irritation for the past month, along with intermittent eye redness. His visual acuity is 20/40 in both eyes. On slit lamp examination, the physician observes scattered epithelial microcysts in both corneas and no other findings. What is the most likely diagnosis? A. Herpetic keratitis. B. Dry eye syndrome. C. Refractive error. D. Contact lens associated keratitis. Answer: B. Dry eye syndrome. Explanation: dry eye syndrome, DES, is the most likely diagnosis in this scenario. The symptoms of intermittent eye irritation and redness, along with scattered epithelial microcysts on slit lamp examination, suggest this condition. DES results from insufficient tear production or poor tear quality, leading to damage of the ocular surface, while herpetic keratitis and contact lens associated keratitis can cause and ocular redness. They typically present with more prominent signs of infection, such as dendritic lesions, herpes, or a history of contact lens use. Refractive error is less likely given the lack of significant visual acuity change 20/40 in both eyes and the corneal findings on examination. Question 2. Scenario-based question. Mr. Thompson, a 50-year-old male with a history of hypertension, presents with a gradual loss of vision in his left eye over the past week. On examination, his visual acuity is 20/40 in the right eye and hand motion in the left. A dilated fundus examination reveals a pale retina with a cherry red spot in the macula. There is also a sudden decrease in retinal artery pulsation. What is the most likely diagnosis and what should be the immediate management approach? A. Central retinal artery occlusion, immediate referral for thrombolysis. B. Central retinal vein occlusion, observation and follow-up. C. Diabetic retinopathy, intraocular injection of anti-VEGF agents. D. Retinal detachment, urgent surgical repair. Answer: A. Central retinal artery occlusion, immediate referral for thrombolysis. Explanation: Mr. Thompson's presentation is highly suggestive of central retinal artery occlusion (CRAO). The cherry red spots seen in the macula, along with pale retinal tissue and decreased retinal artery pulsation, are characteristic findings. CRAO is an ophthalmic emergency that requires urgent management. Immediate referral for thrombolysis or ocular massage to attempt to restore retinal circulation is critical in the first hours of symptom onset. Central retinal vein occlusion (EREO) is less likely to cause the cherry red spot and would typically present with more diffuse retinal hemorrhage. Diabetic retinopathy is also unlikely given the absence of the characteristic findings such as microaneurysms or cotton wool spots. Retinal detachment, although serious, does not present with the features of arterial or cherry red macula. Question 3. Which of the following conditions is most likely to be associated with a relative afferent pupillary defect, RAPT? A. Glaucoma. B. Optic neuritis. C. Cataract. D. Macular degeneration. Answer: B. Optic neuritis. Explanation: a relative afferent pupillary defect, RAPT, also known as a Marcus Gunn pupil, occurs when there is an asymmetry in the afferent visual pathways, typically due to a lesion in the optic nerve or retina. Optic neuritis is the most common cause of RAPT and is often associated with demyelinating diseases like multiple sclerosis. RAPT is detected using the swinging flashlight test, where the affected eye does not constrict as strongly when light is shone into it compared to the unaffected eye. While glaucoma, cataract, and macular degeneration can all cause vision loss, they do not typically produce RAPT, as they usually affect the retina or the anterior segment without causing significant damage to the afferent visual pathways. Question 4. A 60-year-old diabetic patient presents with sudden onset of blurred vision in the right eye. On fundus examination, you notice multiple microaneurysms, hard exudates, and macular edema. The retinal findings are consistent with non-proliferative diabetic retinopathy (NPR). What is the most appropriate next step in managing this patient? A. Laser photocoagulation for retinal edema. B. Intravitreal injection of anti-VEGF agents. C. Observation with frequent follow-up. D. Systemic corticosteroids to reduce inflammation. Answer: C. Observation with frequent follow-up. Explanation: this patient's presentation is indicative of non-proliferative diabetic retinopathy (NPR), which is characterized by microaneurysms, hard exudates, and macular edema. In the absence of proliferative changes, such as neovascularization, the initial management approach is often observation with close monitoring for progression. If macular edema worsens or vision becomes significantly impaired, interventions such as laser photocoagulation or intravitreal anti-VEGF injections may be considered. Systemic corticosteroids are not appropriate in this context as they do not address the underlying retinal pathology of diabetic retinopathy. Anti-VEGF injections are primarily used in more severe cases such as diabetic macular edema (DME), especially when it impacts vision. Question 5. A 45-year-old woman with a history of thyroid eye disease (TED) presents with proptosis and difficulty closing her eyelids. On examination, there is conjunctival chemosis, eyelid retraction, and palpable orbital masses. What is the most likely diagnosis and what would be the appropriate next management step? A. Orbital cellulitis, initiate systemic antibiotics. B. Thyroid eye disease, initiate steroid therapy. C. Orbital lymphoma, proceed with biopsy and imaging. D. Idiopathic orbital pseudotumor, initiate oral steroids. Answer. B. Thyroid eye disease, initiate steroid therapy. Explanation. Thyroid eye disease (TED) is the most likely diagnosis in this case, given the history of thyroid disease, proptosis, conjunctival chemosis, and eyelid retraction. TED is an autoimmune condition typically associated with hyperthyroidism or Graves' disease, leading to inflammation of the extraocular muscles and orbital tissues. The initial management often involves corticosteroids to reduce inflammation and swelling. Orbital cellulitis would typically present with fever and more pronounced systemic infection signs, making it less likely. Orbital lymphoma would not cause such rapid and symmetric proptosis and would be confirmed with imaging and biopsy. Idiopathic orbital pseudotumor could also present with orbital masses, but is less likely to be associated with thyroid disease and would require further investigation. Question 6. A 70-year-old patient with a history of primary open-angle glaucoma presents for a routine follow-up. His intraocular pressure IOP is measured at 24 mmHg in both eyes, and there are no signs of acute angle closure or optic nerve damage. What is the next best step in management? A. Increase the dosage of topical beta blockers. B. Add a prostaglandin analog to the treatment regimen. C. Initiate oral carbonic anhydrase inhibitors. D. Proceed with trachelectomy surgery. Answer. B. Add a prostaglandin analog to the treatment regimen. Explanation. In the management of primary open-angle glaucoma, POG intraocular pressure IOP control is paramount. Given that the patient's IOP is above the target range, typically under 20 nmHg, the next step would be to escalate therapy. Prostaglandin analogs are often used as first-line agents to reduce IOP because they are effective, well tolerated. Once daily, increasing the dose of topical beta blockers or adding oral carbonic anhydrase inhibitors might not provide sufficient additional IOP-lowering effect or could cause undesirable side effects. Surgical intervention like trachelectomy is considered only if medical management fails. Question 7. A 28-year-old male presents with a complaint of double vision, especially when reading. On examination, you find a right eye that is unable to adduct, and there is a mild ptosis with anisocoria. The pupil in the right eye does not constrict as much as the left when light is directed at it. What is the most likely diagnosis? A. Oculomotor nerve palsy. B. Trochlear nerve palsy. C. Abducens nerve palsy. D. Myasthenia gravis. Answer. A. Oculomotor nerve palsy. Explanation. This patient's findings of an inability to adduct the eye, ptosis, anisocoria, and relative afferent pupillary defect are consistent with oculomotor nerve palsy. The oculomotor nerve cranial nerve omen is responsible for most eye movements, including adduction, elevation, and depression, as well as the pupillary light reflex. Palsy typically results in ptosis, impaired eye movement, and dilation or relative afferent pupillary defect due to parasympathetic involvement. The other options, such as trochlear undermine and abducens undermine of palsies, affect different eye movements, downward and outward gaze, respectively, and myasthenia gravis typically presents with generalized muscle weakness that worsens with prolonged use, not isolated ocular muscle weakness. Question 8. A 56-year-old patient presents with visual disturbances after undergoing cataract surgery 6 weeks ago. On fundus examination, you find a flat retina with a localized area of yellow-white discoloration near the macula. The patient also reports having visual halos. What is the most likely cause of these findings? A. Retinal detachment. B. Postoperative cystoid macular edema. C. Endophthalmitis. D. Diabetic macular edema. Answer. B. Postoperative cystoid macular edema. Explanation: the patient's symptoms of visual disturbances and halos, along with the presence of a localized yellow-white discoloration near the macula on fundus examination, suggest postoperative cystoid macular edema. CME is a known complication of cataract surgery, typically presenting within 2 weeks postoperatively. It is characterized by the accumulation of fluid in the macula, causing distortion of vision. Retinal detachment typically presents with more dramatic symptoms such as flashes of light and floaters, and would involve a more diffuse retinal tear. Endophthalmitis, a severe postoperative infection, would present with pain, redness, and significant vision loss, which are absent in this case. Diabetic macular edema would usually occur in diabetic patients and would have more diffuse changes on examination. Question 9. A 30-year-old woman presents with complaints of eye pain, photophobia, and redness. On examination, there is circumlimbal injection, a fixed and dilated pupil, and a shallow anterior chamber with a high intraocular pressure IOP of 4 mmHg. What is the most likely diagnosis? A. Acute angle closure glaucoma. B. Uveitis. C. Scleritis. D. Conjunctivitis. Answer A. Acute angle closure glaucoma. Explanation: the combination of eye pain, photophobia, circumlimbal injection, a fixed and dilated pupil, shallow anterior chamber, and elevated IOP is indicative of acute angle closure glaucoma. This condition occurs when the angle between the iris and cornea becomes narrow, preventing proper drainage of aqueous humor, leading to a rapid increase in IOP. Uveitis would typically present with localized inflammatory response and no significant increase in IOP. Scleritis, although painful, would not typically cause the same degree of visual disturbance and IOP elevation. Conjunctivitis typically presents with redness and discharge, but without the involvement of the deeper structures of the eye, such as the iris and anterior chamber. Question 10. A 45-year-old male presents with bilateral floaters and blurry vision, especially in his peripheral vision. He denies trauma and is otherwise healthy. On examination, he has no evidence of retinal detachment or diabetic retinopathy. Fundus examination reveals a vitreous hemorrhage, but the retinal findings are normal. What is the most likely diagnosis? A. Retinal vein occlusion. B. Posterior vitreous detachment. C. Diabetic retinopathy. D. Age-related macular degeneration. Answer B. Posterior vitreous detachment. Explanation: the presence of bilateral floaters and blurry peripheral vision in an otherwise healthy 45-year-old suggests a posterior vitreous detachment, a common age-related condition where the vitreous body separates from the retina, often resulting in floaters and sometimes blurry vision. The lack of retinal findings on fundus examination and the absence of signs of retinal detachment, diabetic retinopathy support this diagnosis. Retinal vein occlusion, diabetic retinopathy, and age-related macular degeneration typically present with more specific retinal changes, such as hemorrhages, exudates, or macular changes, none of which were noted in this case. Question 11. A 65-year-old male with a history of hypertension and hyperlipidemia presents with sudden loss of vision in his left eye. On examination, you notice a pale retina with a cherry red spot at the macula. What is the most likely diagnosis? A. Central retinal vein occlusion. B. Central retinal artery occlusion. C. Diabetic retinopathy. D. Retinal detachment. Answer B. Central retinal artery occlusion. Explanation: central retinal artery occlusion (CRAO) typically presents with sudden, painless, unilateral vision loss. The classic finding on fundus examination is a pale retina with a cherry red spot at the macula, which is due to the retinal ischemia and the underlying choroidal circulation still being visible through the fovea. CRAO is often associated with emboli from systemic sources, such as artery disease or atherosclerosis. Central retinal vein occlusion (ERA) would present with retinal hemorrhages and venous engorgement, not a cherry red spot. Diabetic retinopathy and retinal detachment would present with more chronic or gradual changes in the retina. Question 12. A 40-year-old female presents with acute vision changes and a headache. She describes blurred vision and occasional double vision. On examination, you find a swollen optic disc with hemorrhages and a significant decrease in visual acuity. The patient also has elevated blood pressure. What is the most likely diagnosis? A. Optic neuritis. B. Papilledema. C. Hypertensive retinopathy. D. Idiopathic intracranial hypertension. Answer C. Hypertensive retinopathy. Explanation. This patient presents with symptoms and signs consistent with hypertensive retinopathy, which is due to chronic or acute high blood pressure leading to damage of the retinal vasculature. The swollen optic disc with hemorrhages and decreased visual acuity is a classic finding in hypertensive retinopathy. Papilledema is usually associated with increased intracranial pressure and would present with more disc swelling without hemorrhages. Optic neuritis is typically associated with pain on eye movement and visual changes related to inflammation rather than hypertension. Idiopathic intracranial hypertension is characterized by headaches, visual disturbances, and papilledema, but does not typically cause retinal hemorrhages. Question 13. A 55-year-old male with a history of smoking presents with gradual central vision loss in both eyes over several months. Fundus examination reveals drusen and geographic atrophy in the macula. What is the most likely diagnosis? A. Diabetic macular edema. B. Retinal vein occlusion. C. Age-related macular degeneration. D. Cataract. Answer. C. Age-related macular degeneration. Explanation. The presence of drusen, yellow deposits, and geographic atrophy in the macula is characteristic of age-related macular degeneration in particularly the dry form. MAMD, a leading cause of central vision loss in individuals over 50 years old, and it is often associated with risk factors like smoking. Diabetic macular edema would present with retinal edema and exudates. Retinal vein occlusion would show retinal hemorrhages and venous engorgement, and cataracts typically cause blurred vision, but not specific retinal findings like drusen or atrophy. Question 14. A 30-year-old woman with a history of systemic lupus erythematosus, SLE, presents with new visual disturbances. On fundus examination, you notice a characteristic candle wax drippings appearance of the retinal vessels. What is the most likely diagnosis? A. Retinal vasculitis. B. Diabetic retinopathy. C. Retinal artery occlusion. D. Retinal vein occlusion. Answer A. Retinal vasculitis. Explanation. The candle wax drippings appearance of the retinal vessels is a hallmark sign of retinal vasculitis, which can be seen in conditions like systemic lupus erythematosus, SLE. Retinal vasculitis occurs due to inflammation of the retinal vessels, leading to leakage and exudation of fluid along the vessels. This can result in the characteristic appearance of the retina. Diabetic retinopathy typically present. Microaneurysms and hemorrhages, while retinal artery or vein occlusions usually present with more acute visual disturbances and retinal ischemia. Question 15. A 48-year-old male presents with a gradual loss of peripheral vision. On examination, you notice optic disc cupping and an abnormal visual field test. What is the most likely diagnosis? A. Retinal detachment. B. Glaucoma. C. Macular degeneration. D. Optic neuritis. Answer. B. Glaucoma. Explanation. The presence of optic disc cupping and abnormal visual field test results is characteristic of glaucoma, particularly primary open-angle glaucoma. This condition is caused by increased intraocular pressure that leads to damage to the optic nerve and gradual loss of peripheral vision, often without significant pain or acute symptoms. Retinal detachment typically presents with a sudden loss of vision and visual defects, but it does not cause optic disc cupping. Macular degeneration primarily affects central vision, and optic neuritis typically causes painful vision loss with associated inflammation. Question 16. A 65-year-old diabetic female presents with blurred vision, particularly in the mornings, and difficulty seeing objects clearly at a distance. On fundus examination, you note microaneurysms, hard exudates, and retinal hemorrhages. What is the most likely diagnosis? A. Hypertensive retinopathy. B. Diabetic retinopathy. C. Retinal vein occlusion. D. Age-related macular degeneration. Answer. B. Diabetic retinopathy. Explanation. This patient's history of diabetes and the findings of microaneurysms, hard exudates, and retinal hemorrhages are characteristic of diabetic retinopathy. This condition is complication of diabetes and results from chronic hypoglycemia leading to damage of the retinal vasculature. Hypertensive retinopathy presents with similar findings but is associated with elevated blood pressure. Vein occlusion would show venous engorgement and retinal hemorrhages, while age-related macular degeneration typically involves the macula and leads to central vision loss. Question 17. A 28-year-old woman presents with sudden onset pain and loss of vision in her right eye. She reports that the pain worsens with eye movement. On examination, there is a relative afferent pupillary defect and the optic disc appears normal. What is the most likely diagnosis? A. Optic neuritis. B. Retinal artery occlusion. C. Papilledema. D. Acute angle closure glaucoma. Answer A. Optic neuritis. Explanation. Optic neuritis is characterized by pain with eye movement, vision loss, and a relative afferent pupillary defect. It is often associated with multiple sclerosis and other demyelinating diseases. The optic disc may appear normal in early stages, and the pain associated with eye movement is a key feature. Retinal artery occlusion presents with sudden vision loss but without the eye pain. Papilledema is associated with increased intracranial pressure and would show optic disc swelling without pain. Acute angle closure glaucoma usually presents with severe pain, nausea, and a visibly dilated, non-reactive pupil. Question 18. A 50-year-old male presents with gradual central vision loss in both eyes. Fundus examination reveals drusen and retinal pigment epithelia (RPE) changes. What is the most likely diagnosis? A. Diabetic macular edema. B. Dry age-related macular degeneration. C. Wet age-related macular degeneration. D. Retinal vein occlusion. Answer. B. Dry age-related macular degeneration. Explanation. The presence of drusen and retinal pigment epithelia (RPE) changes is characteristic of dry age-related macular degeneration (AMD). This is the most common form of AMD and leads to gradual, painless central vision loss due to the accumulation of drusen and the degeneration of the macula. Wet AMD, on the other hand, involves choroidal neovascularization and lead to more rapid and severe vision loss. Diabetic macular edema presents with retinal thickening and exudates, while retinal vein occlusion shows retinal hemorrhages and venous engorgement. Question 19. A 42-year-old male presents with acute, painless loss of vision in his left eye. Fundus examination reveals a pale retina with a cherry red spot at the macula. What is the most likely cause of this patient's condition? A. Embolism from a cardiac source. B. Retinal vein occlusion. C. Diabetic retinopathy. D. Retinal detachment. Answer A. Embolism from a cardiac source. Explanation. Central retinal artery occlusion often presents with a pale retina and a cherry red spot at the macula. This condition is most commonly caused by embolism from a cardiac source, such as atherosclerosis or a carotid artery thrombus. The embolus obstructs the retinal artery, leading to retinal ischemia. Retinal vein occlusion typically presents with retinal hemorrhages and inguinal veins. Diabetic retinopathy and retinal detachment would have different retinal findings and usually do not present with a cherry red spot. Question 20. A 60-year-old male presents with a history of severe headaches, nausea, and vomiting, along with gradual vision loss. On fundus examination, bilateral optic disc swelling. What is the most likely diagnosis? A. Papilledema. B. Glaucoma. C. Retinal vein occlusion. D. Optic neuritis. Answer A. Papilledema. Explanation. Papilledema is the swelling of the optic disc due to increased intracranial pressure, and it often presents with symptoms such as headaches, nausea, and vomiting, in addition to visual disturbances. The bilateral optic disc swelling on fundus examination is characteristic of this condition. Glaucoma would present with optic disc cupping, while retinal vein occlusion would show hemorrhages and engorged veins. Optic neuritis typically presents with pain on eye movement and a relative afferent pupillary defect rather than bilateral optic disc swelling. Question 21. A 45-year-old woman presents with acute vision loss in her right eye following a period of headache and scalp tenderness. On examination, there is a swollen optic disc and the visual field is reduced. What is the most likely diagnosis? A. Giant cell arteritis. B. Retinal artery occlusion. C. Optic neuritis. D. Diabetic retinopathy. Answer A. Giant cell arteritis. Explanation. Giant cell arteritis (GCA) is an inflammatory condition of the large arteries, commonly affecting the temporal arteries. It can lead to vision loss due to optic nerve ischemia. The associated symptoms of headache and scalp tenderness, along with optic disc swelling, are classic signs of DCA. Retinal artery occlusion presents with sudden, painless vision loss but without the systemic symptoms. GA. Optic neuritis is associated with pain and typically affects younger individuals. Diabetic retinopathy presents with retinal hemorrhages, exudates, and microaneurysms, not acute vision loss. Question 22. A 50-year-old male with a history of hypertension presents with sudden, painless vision loss in his right eye. On fundus examination, there is a blood and thunder appearance with extensive retinal hemorrhages. What is the most likely diagnosis? A. Diabetic retinopathy. B. Retinal vein occlusion. C. Retinal artery occlusion. D. Hypertensive retinopathy. Answer: B. Retinal vein occlusion. Explanation: retinal vein occlusion are often present with a blood and thunder appearance, characterized by extensive retinal hemorrhages and venous engorgement. It is a common complication of hypertension and can lead to sudden vision loss. Diabetic retinopathy presents with microaneurysms, hard exudates, and retinal hemorrhages, but does not typically present with the blood and thunder appearance. Retinal occlusion presents with sudden vision loss but without hemorrhages. Hypertensive retinopathy would show retinal changes like cotton wool spots and have nicking but not extensive hemorrhages. Question 23. A 30-year-old male with a history of multiple sclerosis presents with acute vision loss in one eye. On examination, there is a relative afferent pupillary defect and the optic disc appears normal. What is the most likely diagnosis? A. Optic neuritis. B. Retinal detachment. C. Retinal vein occlusion. D. Glaucoma. Answer: A. Optic neuritis. Explanation: optic neuritis is a common presenting feature of multiple sclerosis. It typically causes sudden vision loss in one eye with a relative afferent pupillary defect and normal optic disc appearance in the early stages. It is often associated with pain, particularly with eye movement. Retinal detachment would present with flashes of light floaters and a visual field defect, but no afferent pupillary defect. Vein occlusion presents with hemorrhages and engorged veins. Glaucoma leads to gradual, painless vision loss and optic disc cupping. Question 24. A 65-year-old woman presents with difficulty reading as well as a dark spot in the center of her vision. On fundus examination, iridescence and atrophy of the retinal pigment epithelium. What is the most likely diagnosis? A. Wet age-related macular degeneration. B. Dry age-related macular degeneration. C. Diabetic macular edema. D. Retinal vein occlusion. Answer: B. Dry age-related macular degeneration. Explanation: dry age-related macular degeneration (MD) is characterized by the presence of drusen and atrophy of the retinal pigment epithelia (RPE), leading to gradual central vision loss, which is often noticed as difficulty reading or seeing fine details. AMD involves choroidal neovascularization and can cause more rapid vision loss with bleeding or exudates. Diabetic macular edema leads to retinal thickening and exudates but not drusen. Retinal vein occlusion can cause macular edema, but it is typically associated with retinal hemorrhages. Question 25. A 55-year-old male with a history of smoking presents with sudden vision loss in his left eye. On fundus examination, you observe a small, round, pale area at the macula. What is the most likely cause of this patient's condition? A. Central retinal vein occlusion. B. Central retinal artery occlusion. C. Retinal detachment. D. Diabetic retinopathy. Answer: B. Central retinal artery occlusion. Explanation: central retinal artery occlusion crowd typically presents with sudden painless vision loss and is characterized by a pale retina with a cherry red spot at the macula. It is most often caused by an embolism from a cardiac source. Central retinal vein occlusion presents with retinal hemorrhages and engorged veins, not a pale retina. Retinal detachment would cause symptoms like flashes of floaters and a visual field defect. Diabetic retinopathy causes a range of retinal changes, but it is less likely to present with a small, round, pale macular area. Question 26. A 40-year-old male presents with a painful red eye, photophobia, and blurred vision in his left eye. He has a history of trauma to the eye. On examination, there's a corneum abrasion and a fluorescein stain reveals uptake in a linear pattern. What is the most likely diagnosis? A. Bacterial keratitis. B. Corneal abrasion. C. Uveitis. D. Acute angle closure glaucoma. Answer: B. Corneal abrasion. Explanation: corneal abrasions are often caused by trauma and present with symptoms of pain, redness, photophobia, and blurred vision. The characteristic finding on fluorescein staining is uptake at the site of injury, which can show a linear pattern. Bacterial keratitis may also present with pain and photophobia, but is typically associated with a white stromal infiltrate. Uveitis presents with a red eye flush, but not with the fluorescein uptake seen in corneal abrasions. Acute angle closure glaucoma causes a painful red eye with high intraocular pressure, often with a fixed, dilated pupil, but it would not present with a fluorescein uptake pattern. Question 27. A 65-year-old woman with a history of hypertension and diabetes presents with decreased vision in both eyes. Fundus examination reveals hard exudates, microaneurysms, and cotton wool spots. What is the most likely diagnosis? A. Hypertensive retinopathy. B. Diabetic retinopathy. C. Retinal vein occlusion. D. Age-related macular degeneration. Answer B. Diabetic retinopathy. Explanation: diabetic retinopathy is characterized by microaneurysms, cotton wool spots, and hard exudates due to leakage from damaged blood vessels. It is a common complication of both type 1 and type 2 diabetes. Hypertensive retinopathy presents with changes such as retinal hemorrhages, exudates, and avnicking. Retinal vein occlusion can also present with cotton wool spots and hemorrhage, but typically presents with blood and thunder appearance. Age-related macular degeneration affects the macula and presents with central vision loss and drusen. Question 28. A 25-year-old woman presents with sudden painless vision loss in her right eye. She has a history of systemic lupus erythematosus, SLE. Fundus examination reveals pale retina and a cherry red spot at the macula. What is the most likely diagnosis? A. Retinal artery occlusion. B. Optic neuritis. C. Hypertensive retinopathy. D. Central retinal vein occlusion. Answer A. Retinal artery occlusion. Explanation: retinal artery occlusion (RAO) is often associated with a pale retina and a cherry red spot at the macula. In this case, the patient's history of lupus, an autoimmune condition, increases the risk of embolism or vascular occlusion leading to RAO. Optic neuritis typically causes vision loss due to inflammation of the optic nerve, but it is associated with pain and no cherry red spot. Hypertensive retinopathy and central retinal vein occlusion typically present with retinal hemorrhages rather than a cherry red spot. Question 29. A 45-year-old man presents with sudden vision loss in his left eye. He has a history of atrial fibrillation. On fundus examination, there are retinal emboli in the central retinal artery. What is the most likely cause of his vision loss? A. Retinal artery occlusion. B. Diabetic retinopathy. C. Central retinal vein occlusion. D. Retinal detachment. Answer A. Retinal artery occlusion. Explanation: retinal artery occlusion (RAO) is commonly caused by emboli, particularly in patients with atrial fibrillation or other cardiovascular conditions. The presence of retinal emboli on fundus examination supports the diagnosis of RAO, which typically presents with sudden vision loss. Diabetic retinopathy causes gradual vision loss, with changes such as microaneurysms, hard exudates, cotton wool spots. Central retinal vein occlusion causes retinal hemorrhages and engorgement of veins, not emboli. Retinal detachment presents with symptoms like flashes of light and floaters, and not with retinal emboli. Question 30. A 60-year-old woman presents with sudden painless vision loss in her right eye. She has a history of atherosclerosis and hypertension. On fundus examination, there is a pale retina with a cherry red spot at the macula. What is the most likely diagnosis? A. Retinal artery occlusion. B. Central retinal vein occlusion. C. Hypertensive retinopathy. D. Age-related macular degeneration. Answer A. Retinal artery occlusion. Explanation: retinal artery occlusion (RAO) is characterized by a pale retina with a cherry red spot at the macula, often caused by embolism or atherosclerosis. This is the classic presentation of RAO, particularly in patients with vascular risk factors such as atherosclerosis and hypertension. Central retinal vein occlusion typically presents with retinal hemorrhages and engorged veins, not a cherry red spot. Hypertensive retinopathy causes changes like avnicking, cotton wool spots, and retinal hemorrhages, but not a cherry red spot. Age-related macular degeneration causes gradual central vision loss and is associated with drusen.